Grayson Woods, a gynecologist right here in town, also native Nashvilleian.
Yes.
I was saying, you guys are more and more rare every day. So your practice is where?
We're located at the Bellmead Hill Center.
And you've been there for a while now.
We have, gosh, 7 years. Yeah.
And I was reading your website and before I came on the show, and you really have the who's who of nurse practitioners. Obviously, your credentials are, 5-star. You've really set up a nice office.
Thank you. I feel very privileged. Yes.
Let's jump off where we stopped in the last segment. We were talking about Pap smears and the different guidelines. When a woman has a hysterectomy, what does that mean for her annual exam, for Pap smears? What does she need to do?
Great question. Great questions. And one of the reasons it's a really good question is because hysterectomies have come to mean different things over the years. And so there's a partial hysterectomy. Sometimes women have the upper part of the uterus removed and leave the cervix in place. Sometimes the ovaries are removed. Sometimes they're not. And so first off, again, it's kind of knowing your anatomy, and that's one of the things I can help with, especially when our patients have had surgery. It's been a long time ago and they're not sure. And so we check that and see, and if their cervix was removed with the uterus and more of a full hysterectomy, then the rates of cervical cancer drop significantly.
Gotcha.
And so that's good news for those women. And yet we do still see vaginal cancers. And so that's the reason that I still recommend Pap smears after hysterectomy. Even though it's very rare, we still see it. We still see that. And so we do the Pap smear on the vaginal tissue to check for that.
It's still on a yearly basis?
Generally speaking, yes.
Okay. And does a hysterectomy mean anything else for patients that you see common in your practice that women should be aware of, maybe if they're considering the surgery, that changes their health at all?
In what ways?
Well, I don't know.
Just in general?
I guess just in general. Women who have come in who have had hysterectomies, do you have any other red flags that usually pop up, or things that you're looking for in those woman exams?
I see. So generally speaking, generally no. Actually, thankfully it's such a safe procedure, and over the years it can be done minimally invasive. Occasionally, women we will see a little bit more prolapsing of the tissue, or occasionally some urinary leaking, but that tends to be infrequent, thankfully.
And not that the hysterectomy means menopause, because it does not, I know that. But let's switch gears and talk about menopause. Such a significant event or journey in a woman's life.
Yes.
What do you want your patients to know about menopause? How do you counsel them?
Well, we spend a lot of time at our office talking about menopause, and I like to describe menopause in the way that for your teenagers are on an uphill roller coaster. Well, things that go up generally come back down, and so menopause is essentially hormone levels coming back down on a downhill roller coaster. And so what you're seeing, and the average age is generally around 50 to 51, and that's defined as not having a period for over a year. And so while that does happen and periods end, the downhill roller coaster is starting generally mid-40s.
Wow.
And so I think one of my main messages is that women tend to experience symptoms much earlier than years before the periods stop, and to be aware of it, and to be aware that there's help for kind of managing the symptoms. Kind of like if a teenager didn't know, you didn't know to expect the changes. In addition to the actual issues, you're wondering what's happening.
Swings and the acne and everything else.
That's right. And so menopausal, or what we call perimenopausal age women, have a lot of the same things: acne, hair changing, falling out or changing texture, mood swings, or PMS can change up, and so it's important to know, hey, this is happening. It's real. There's support. There are things we can do. There are non-medical, things we can do, herbal things and exercise and dietary things we can do.
Well, let's talk about that. And I do want to remind everybody, if you have a question, I will stop asking the questions. You can call in 615-737-PLUS. Until then, let's talk about those options for women, whether they're in the perimenopause or full-fledged in menopause, and dealing with those changes. Medically, let's start there. What can you do?
Well, medically, what we can do, there are several options. Again, first are drawing blood levels to see, what can we assess from that. We always want to exclude thyroid, vitamin deficiencies, and other things. And then, the broadest is hormone replacement therapy. So that is definitely an option. It's probably the most common option that women choose, and most effective. As you consider what's happening, again, which is this downhill roller coaster, where the ovaries are beginning beginning to lose the remaining eggs, and therefore the hormone is ceasing, to come in and replace. I tell women, a lot like when your thyroid starts to slow down or shut down, our goal is really to replace what's missing, and that will generally resolve most of the symptoms, whether it's the mood, the flashes, and so on. And that's with a full discussion about potential risk, which is a whole, another subject we can talk about too.
Yeah.
But that's the main idea, is that, we want to come in, if we're going to choose hormone replacement therapy, that it's as natural as it can be, plant-based and synthetic, to really try to mimic what your body was making before and really just reach the levels where you were. There's that, and there are varieties of hormone replacement therapy. There are also the medicines in the antidepressant family, the SSRIs, the serotonin reuptake inhibitors. Those can really help significantly, especially if mood symptoms are predominant. There are also herbal supplements. We know black cohosh, and gosh, there's a long list that can really be effective.
And if you're looking at, if a woman comes in and says, I'm having these symptoms, I'm just not myself, I had these hot flashes and mood swings and whatever. If you're then looking at hormones at that point, how hard is it to say, well, here's where I think you probably were, and we need to get back to there? If you're already looking at hormones that are, I can only imagine.
And the reason too, again, is because the roller coaster ride is kind of wild. It can be wild, and so again, we do our best with checking serum levels. Some places check saliva levels to try to get a gauge. So we do two things. We want to both look at the lab values and really do a thorough assessment of what are the symptoms, how are you feeling, what's happening, what's negative, what kind of negative symptoms are we having, to mostly get those restored back to normal. So we really look at both. We never want to just look at labs or the other in combination.
I imagine this is a time where women it's not a one-stop shop quick fix. Okay, I'm sitting out the door with this prescription and there you have it.
I wish.
Yeah, I mean, it has to really be part of the journey, I would imagine.
It is.
And women have to take note of their health. What do you tell women to really notice and maybe jot down, journal?
Right, diary, that's right, diary. Sometimes I'll recommend a diary like at the end of the day, based on the key, some of the key symptoms that they're having, to kind of rate them at the end of each day, because after a week or so with a busy plate of life and kids and other things, it's hard to remember.
Yeah,
it is, and so that's a good way.
And then you can take that in and say, okay, here's where I have been over the past month or the past 6 months, and what can we do about it?
That's right. And because some days can be better than other days, again, as women, busy and doers and go and take care of family, so we tend sometimes to neglect ourselves, and then one day's better, so then it feels like, oh, well, I'm doing better now, and so we sometimes will dismiss and wait and wait and wait and wait.
Right, you always put yourself on the back burner.
Sometimes the family members are bringing
you need to go.
That's right.
Yes, you have changed.
So, just to monitor, write them down, and that helps us as the providers to say, which are the key things that are so bothersome that we can help with or walk through.
You mentioned some of the health risks that come with the hormone replacement therapy, and that made the news a long time back about the heart issues, and it still has to be top of mind for a lot of women when they hear hormone replacement therapy.
Yes.
What's your word of caution, advice? What do you look for?
Well, it sounds, can sound really scary for a lot of folks, and because that data that came out in 2002 was a really big study and it got lots of PR, it felt really scary then and can feel really scary now too. So we walk through that data and what it means, and and again, we're generally, and I'm a minimalist, so I generally want to take as few things as possible if I can, and yet I do want to live my life fully and feel as well as I can. So we're talking about optimizing health and wellness too, and so we really walk through that. So if we don't need it, then we may not need it at all, or a lot of times we'll try some of the other options first and see. But the data, unfortunately, there's really not great data on what we currently use. So the overwhelming majority of data from 2002 was from Premarin and Prempro that we rarely use. So
is there a new study in the works, or
no? There's not really. So
that's unfortunate.
It really is. It is. And so, and one of the issues with that data, and again, I could take up a lot of time talking about that, but the average age for the participants was 65. So one of the things we know now is that it benefits women so much more if they start around the time 45 to 50 to 55 and not wait a really long time, because their systems have adjusted. And so we think a lot of the negative side effects were because their bodies had adjusted, and then suddenly there's something new, you know, being introduced. And
once you decide to go the route of hormone replacement therapy, or even if you're going the natural route, is this something you're doing for the rest of your life?
No, not necessarily, not at all. And so generally, and again, one of the decision, you know, factors when we're talking is that, you know, with these menopause symptoms, we don't know how long they're going to last. And so for some women, it's 6 months. Some it's 2 years, some it's 10. And we don't have a crystal ball or a lab value or an objective way to know. And that makes it really challenging. So again, we come back to what's happening, how bad is it, how quickly do we need to act? And then generally we try to do the shortest amount of time possible. So I tell folks, depending on the severity, we may say, you know what, let's just get optimized and really try to stay there for 6 months to 12 months, and then let's see. And, and then we can try to wean down and test it. And usually the testing tells you it's either A-okay outside or it's not, and then you got your answer.
Well, good. That explains a lot. We're going to have to take another quick break. When we come back, your questions, if we get some calls, we will take them for sure. If not, I'll keep asking the question of Dr. Woods. Hope you're enjoying the show. We're talking women's health tonight. Stay with us.